talk. Now I invite Dr. Kaushik Murali sir for the keynote address.
Good morning. At the outset, I would like to thank KSOS and Dr. Sahasranam for inviting me to be a part of this session. It always is a pleasure to come back to the Kerala conference. The warmth and the camaraderie that you see here, you don't often see in most other ophthalmic meetings. It's always a pleasure to be back here. Again, before I start my presentation, I would like to acknowledge some of my colleagues who contributed towards some of the videos and pictures that I would be showcasing as a part of this. I acknowledge Dr. Saumya, Dr. Nishant and Dr. Kavita who helped me put together this. What I'm going to be sharing with you is trying to make sense of twists and turns that we see in terms of anomalous head postures in children. Again, the intention is not to scare you, but we also understand that this is something that every ophthalmologist may come across in their clinic. And when you come across this, what can you practically do or what can you do in your own setup is what we are trying to walk you through. So first, to start off, you need to understand that torticollis or any twisted posture comes from this combination of two words, tortoise and column, which literally translates to twisted neck. So when you look at any eye condition leading to an anomalous head posture, we refer to it as ocular torticollis. So whenever a patient derives advantage by adopting it, it may actually make more sense for us to call it as a compensatory head posture rather than as an ocular torticollis, because there is some functional improvement that the child or the adult actually undertakes. So that is something that has been suggested earlier, but we will stick with ocular torticollis for the basis of this presentation. So again, a child who has a twisted head or a torticollis may do so because of ocular conditions, because of inner ear conditions, or due to some issues in the entire muscle spindle. And what you need to understand is that anomalous head posture is not a diagnosis, but rather is a sign of some underlying disorder. And as ophthalmologists, I think we need to spend a little bit more time in trying to identify what the potential cause could be. Now, when you look at the eye in a torticollis, again, you need to understand that the head may or the face may be tilted in three potential directions. So it could be around the x-axis where you have a little bit of a turn. It could be around the z-axis where you have a little bit of a face turn happening, and along the y-axis where you have a chin up or a chin down happening. So let's just look at it one at a time. Now, how do we measure it? There have been various devices that have been created to measure this, that have gyroscopes, that have magnets put. But the simplest way to do it is to use a scale and a protractor, or use an orthopedic goniometer with a protractor and measure it. So here we are actually measuring a face turn. So if you look at it, you're looking at the rotation of the anterior posterior axis from the normal position that is there. So you just keep the protractor perpendicular and then you measure out on the scale saying that how many angles has the face actually been turned. Next, when you're looking at the chin up or the chin down position, so here you keep one arm that is perpendicular to the fixation target. So you ask the child to look straight ahead, and with the other you align it with the anterior posterior axis of the skull. So that again gives you in terms of angles as to how much up or down the child is actually keeping their face. Head tilt becomes a little tricky because again there is some amount of parallax, you're standing behind the child. But here again the key is to try and keep it perpendicular to the floor, and the other arm you align it to the axis of the face, and again you can get a reasonably good, reliable, a repeatable kind of a measurement by using this very simple device that all of us would have access to. So the Taylor and Hoyt textbook of pediatric ophthalmology carries this lovely table that kind of encapsulates what all potential conditions can be. The reason I put it here is that not all torticollis is necessarily because of the eye, and not all torticollis can you blame it on musculoskeletal anomalies. So it could happen because of trauma, it could happen because of certain congenital issues. Of late, practically, I'm seeing a whole lot of children where the parent will say that the child turns his face when he's watching TV. We've done refraction, we've broken our head, we've sent him for an MRI. Finally, what you realize is the child has wax in one ear. He's not able to hear clearly, and he turns his head actually to the ear that he can hear better. So now as a protocol, we almost tell every parent saying that, have you put Solivax or Vaxonil in the child's ear. Otherwise, next time you take him to the pediatrician, please get the hearing tested. So that is something that we found as a hack that works in a number of children, especially from a non-ocular cause. Skeletal anomalies, muscular paresis, all of these can cause certain issues. These largely would fall under what are the non-ocular. Among the ocular, again, we'll come back to it. The most common, which all of us can handle, continues to be actually refractive errors. We often forget that refractive errors can cause an issue, visual fields can cause an issue. A drooping of a bilateral ptosis could make the child take a chin up position. Then of course you have other issues like paresis, restrictive strabismus, and other mechanical restrictions that could come into play. And sometimes there also could be a congenital torticollis. So invariably, whenever we find a finding, we get kind of obsessed with it as clinicians and try to dive very deep into it. A torticollis or an anomalous head posture, the first thing that we need to do is to look at the person as a whole. So in this child, it looks like he's having a chin up. Probably if we gave it as a spotter, lot of us would say probably he has a bilateral ptosis and that's why he's doing it. But when you look at the entire body, it is very obvious he's got a skeleton anomaly that makes him adopt that kind of a peculiar posture, and you cannot do anything as an ophthalmologist to correct it. So all we need to do is refer him to an orthopedic surgeon. So we need to look at the child as a whole. The next question comes saying that you need to figure out saying that is it ocular, non-ocular. The simplest way to do it is ask the child to close their eyes and hold the head straight. So and try to kind of move the head in one or two random directions with their eyes closed. If they're able to maintain it, then probably it is non-ocular. That becomes the simplest way of kind of classifying whether it is ocular or non-ocular. Now the next question then comes, okay, we figured out it is ocular, is it one eye or two eye? So here if you look at it, we are occluding one eye, the AHP remains, and slowly you occlude the other eye, the AHP will continue to kind of remain in the girl that you see here. But when you look at the boy on the other side, the minute you occlude one eye, you will notice the AHP kind of marginally get better. But when you occlude the other eye, it almost completely disappears. So it's very clear that that is an AHP where one eye is involved, whereas here you have both the eyes involved. So that way, algorithmically, you can arrive at what is happening. Now, an AHP can happen in a variety of ocular causes, right from strabismus, nystagmus, to refractive errors and field defects. Why does this happen is again very simple. It will happen if the child can actually improve their visual acuity or binocularity. AHP in a child indicates that there is functional vision possibly in both the eyes, especially in infants where you see a tilted head. You can relax a little bit. That means the child is possibly using both the eyes, and to maintain binocularity is why they are adopting that particular posture. It is very rarely seen following vision loss in one eye, where to obviate diplopia, the child adopts a posture to actually take it away from the fusional range. That has been reported. I have not seen too many of these conditions. Again, that is something that back of the head we need to remember. To reiterate, ocular torticollis is driven by the need to optimize visual acuity, to maintain single binocular vision, and to center a narrow field with respect to the body. So this becomes especially important in terms of nystagmus children. So in any child, the first thing to do is to correct the AHP and observe. The minute you correct the AHP, the squint becomes very obvious. So you know that you're going to be handling a possible strabismus in the girl. And in the other one, you need to check ocular movements. You can use a toy, you can use a fixation stick, you can use pretty much anything that can attract the child's attention. Something with sound works well. A smartphone with a small video playing is also as effective as an object for you to check ocular movement. So you can play a cartoon of YouTube and attract the child's attention. So that works really, really well. So once you check the ocular movements and figure it out, you know, then arrive at some kind of a possible diagnosis. So in this particular child, you've done a kind of a, you've arrived that it is binocularly driven by the previous things. You've looked at the ocular movements, and with that you can then arrive at a diagnosis of it being a possible left superior oblique palsy. So in any of these strabismus conditions, what you need to remember is the head will move to where the eye cannot move. So that is the simplest way for you to figure out saying that which possible muscle is affected or what range of movement is affected by just looking at how the posture is maintained. That can help you, because what the child is attempting to do is to avoid diplopia. In infantile nystagmus, again, we know that there is something called as the null zone. The null zone is that position in gaze where the nystagmus is dampened, and with the nystagmus becoming dampened, the visual acuity automatically gets better. So in this case, you will notice that the face turn kind of dampens the nystagmus. I apologize, the video is small, it may not be very evident. But whenever this null zone is not in the primary position, you will see children with nystagmus keep their face straight. So that probably is because the null zone is in the primary position. Whenever it is not in the null zone, they will adopt an AHP. They will adopt an AHP not all the time. So when they're talking to you, they may not. But when they have to actually use their vision, when you ask them to read a distance vision chart, is the easiest way for you to elicit that potential null point that will kind of be triggered by the AHP there. So this again is obviously not a child, but I put this here because again it's one of a very interesting case. So it's very clear, this is a right face turn, but when we correct his posture, eyes are straight. And this is a patient who does not have nystagmus. Now you are kind of confused saying what the hell is going on. So in this patient, whenever you see such a condition where you correct the posture, you don't see a nystagmus, you need to do a visual fields. So here what do you see? You see a very clear homonymous hemianopia. So when you put both of this together, you need to understand that the face turns towards the defected side with gaze, and it is usually towards, it gives a preference to the contralateral side to the field defect, or it is ipsilateral to the field defect. So why this does is because this adaptive posturing that the patient undertakes expands his useful peripheral field. So by turning his face, he is making sure that he is able to turn his eye to the side that he can see better. So that again gives you some idea. So wherever the head posture gets corrected, you don't see a nystagmus or a squint. As ophthalmologists, please get a visual fields done. That will probably give you a clue as to what else is happening there. Again, the most common thing that we see in most children is something that we should not forget. A majority of anomalous head postures or compensatory head postures continue to be because of refractive errors, and that is something very, very key. So this child had this extremely gross error. The minute you put a pair of glasses, almost miraculously you see the head go straight. So the first thing that we need to do in all of these children is to refract them and make sure that they have an appropriate correction. So face turn again is most common in myopia and against the rule astigmatism. Again, just putting a simple pair of glasses will help correct it. Head tilts happen. Now most of us will have a small cylindrical power that allows us to see a little clearer, and we don't correct it. But take a simple trial frame that is there and just twist it around with the target. You would see the kind of change and distortions that happen. So whenever the visual axis does not coincide with the optical axis, if the prescription is very weak, the child will turn their head to fixate through the peripheral part of the lens. Because look at that schematic on top. The minute it goes a little bit of an off center, pretty much for every few millimeters, it adds in a lot of plus there. So the child will struggle to see, even if a plus lens is offset, because it then induces a prismatic effect. So that becomes very important for the child to be able to focus very clearly. So look at this girl. She's got a frame that is tilted. She's correctly prescribed. So this is how she would see. So we just pulled it out and took an image. Now obviously she's not going to be happy looking the way the image on the right is. She's going to adopt a face turn. And this is something again you'll very commonly see. Place a frame on your table. You will find one part of the frame completely lifted up. The other thing that we also see very often with lot of the lenses getting fitted is they come in 60 mm blank. So they just cut it out and put it to the center of the frame. That may not be centered to the optical center. So the minute you see a child where you provide glasses, still the child is tilting the head, the first thing to do is figure out whether the frame is okay. Second, check for the optical centration and check whether that is all right. If that is not all right, that becomes something that we need to do. A chin up again gives an advantage of a stenopic slit, and again you see it a lot more common in both myopia and astigmatism. Correcting glasses again helps you get that corrected very well. A chin down has been reported in moderate hyperopia because it is thought that there is some divergence that is physiologically there, and it kind of increases the amount of accommodation without convergence that would be there when the child is looking in the primary gaze or in the down gaze. So that kind of helps the child to over accommodate in a sense and cover up some part of the hyperopia that the child has. So again, any hyperopia in a child with the chin down position preferably should be corrected. So to sum up, to make our life very easy, first thing first, figure out what is happening, figure out whether it is an ocular or a non-ocular anomalous head posture, whether it is binocular or uniocular, and then start getting into action. You don't have to look for a specialist. Correcting a refractive error is something every one of us in this room can do. Getting the visual field tested is something that every one of us can do. We need to understand that the child is adopting it probably to gain visual acuity, binocularity. Looking for nystagmus is something very, very simple. And even after we correct it, if we find certain things, then is where you need to do a cover test, look for the ocular movement. So don't hassle yourself saying that, oh my God, is this a V pattern, A pattern, what is going on? Keep it simple, do the stuff that you know that you do routinely, and then we can try and help these children see better. So once again, I thank you all very much for this opportunity.
So thank you, Dr. Kaushik, because it's a very sort of very tricky situation, because the parents are very much concerned. It's because of the cosmetic problem it produces, and to evaluate an abnormal head posture, no, it's a very difficult situation. So unless you are thorough with what is happening in ocular causes of AHP, it needs an algorithmic approach to evaluate it, and that was and your talk was very elucidating. So thank you for accepting our invitation and be a part of this session. And